So the menstrual cycle might be skipping a few months. You just feel off, not yourself, maybe hot flashes, things like that. Big question, is somebody in early menopause? Or what we often might term, another term is primary ovarian insufficiency. Does this apply to you? So let's go over it. Welcome back to the New School OBGYN. My name is Eric Schmidt. I'm a board-certified OBGYN, minimally invasive gynecologic surgeon, and it matters where you get your information here at the New School OBGYN. And so today we're going to be talking about early menopause and primary ovarian insufficiency, or what was previously known as primary ovarian failure. Okay, let's go through some of these terms and define them. So early menopause is when menopause happens between age 40 and 45. Now, menopause, again, is absence of menses for 12 months. So if someone is between the age of 40 and 45 and they don't have menses for 12 months in that time consecutively, that might be because of potentially early menopause. Okay, and this affects approximately 3 to 5% of the population. Actually, by a lot of our previous guidance on gynecology and menopause, this didn't necessarily need to be worked up. And that's kind of what we learned. That's what we were taught going through school and residency. But actually, I would totally work this up now. This deserves to be worked up because potentially if someone's without that estrogen that is protecting them, it may have potentially negative effects going forward. So yes, if somebody is going through menopause this early, you deserve to get evaluated by your doctor and provider to investigate it further and potentially treat it. Okay, so primary ovarian insufficiency, or what used to be called primary ovarian failure, and we'll get to why we kind of changed that terminology a little later on in the talk, but that is when somebody goes through their menopause before the age of 40, and so that's pretty early. It can even be earlier than that, potentially in someone's 30s, 20s even. And so, again, 12 months without menses or amenorrhea would give somebody this diagnosis if it happened before the age of 40. And often this is confirmed with a laboratory test because, well, we didn't say early menopause, what we said previously, didn't necessarily need a workup. Not what I believe, but that's what the textbook says. I do believe, or everyone believes, that the primary ovarian insufficiency needs workup and treatment, definitely. Primary ovarian insufficiency affects approximately 1% of the population, so that's not exactly rare. Okay, so for the rest of the talk, we're mainly going to be talking about primary ovarian insufficiency. However, it does somewhat apply to early menopause also. So if somebody is in their 30s or 20s and they are skipping multiple menstrual cycles in a row, and not just one or two, but like 3, 4, 5, 6, you should get evaluated sooner than that 12 months. You shouldn't wait 12 months to potentially get evaluated by your doctor. And so, especially if you're having symptoms, things like hot flashes, night sweats, other changes in your body, mood changes, cognitive changes, along with that, those other signs of menopause, which we talked about in the previous episodes, if that's happening to you in your 30s and in your 20s, especially with missing a bunch of cycles, come in, get checked out before those 12 months. And how do we diagnose it? Mainly with a couple different labs called an FSH. This is hormone secreted by the body, and it helps stimulate the follicles in the ovary to grow. And so if those follicles in the ovary are few or none, that FSH level is really high because the body is trying to get those ovaries to create those follicles to ovulate and to potentially get pregnant. So if that FSH is really high, that means that the ovary is not responding and maybe potentially decreasing its function. And then with that, often the estrogen is going to be low, okay? Not in the normal range where it should be in someone's cycle. And so if by chance someone has some irregularities in their lab tests when they're getting these initial FSH levels tested or estrogen levels tested, we often confirm that test a few months later down the road because sometimes these hormones can significantly fluctuate throughout someone's cycle. So we generally try to reproduce that abnormality in the next few months. But we're also going to be doing other things because things like thyroid hormone abnormalities can significantly impact and basically cause all those symptoms if someone has low or potentially high thyroid. Elevated prolactin levels. And of course, as the textbook would say, and I'm sure every patient that was in this scenario did, but check a pregnancy test. But that's just the initial workup. The workup will go further if you meet the diagnosis. Next question, why does this happen? Actually, the most common reason would be genetic. And so does someone have a potential genetic abnormality that may lead to this? This is why often, or we do recommend patients with primary ovarian insufficiency to get karyotype, or basically their genetics laid out to see if there's any significant abnormalities. Some common situations which someone may have an increased chance of primary ovarian insufficiency would be like Turner syndrome, Fragile X, or other potential translocations within the genetics. There also can be autoimmune diseases or certain toxins or infections that can affect the ovaries, like mumps, can infect the ovary and decrease its function for the longevity. Also, there can be potential environmental things that can cause ovaries not to work to their full potential. And I think that probably deserves its own episode in the future. I didn't exactly talk about this before, but if somebody has surgical menopause, meaning they had their ovaries removed, kind of excluding that from our talks here. So in the previous talks, we talked about the significant symptoms and significant deleterious effects of low to no estrogen in a woman's life can have. We talked about it around the time of a normal menopause transition. Well, if that transition happens 10, 20 years sooner, the significant effects, whether it's cognitive function, whether it's somebody's ability to be comfortable throughout the day with the hot flashes, night sweats, whether it's the dementia, whether it's the sexual health changes, or cardiovascular disease increase, osteoporosis degree increase, that if that low estrogen happens in someone's 20 or 30s or 40, early 40s, can have significantly more impact on that person's longevity, their health going forward, than if it happens a little later on. So for somebody that has primary ovarian insufficiency or failure, old term, we definitely recommend treatment as long as they don't have any contraindications to hormonal therapies. And so one of the best treatment would be hormone replacement, which is a low-dose estrogen. If someone still has their uterus, we often need the progesterone to protect it. Some people do believe that progesterone has its own benefits too, outside of that, but if someone has a uterus still, they can't just do estrogen. It could increase their chance of abnormalities or cancers of the uterus. But yeah, if someone meets that diagnosis, we need to talk about treatment to prevent all these bad things that we talked about a minute ago. Now, one of the more difficult situations that arises from this is that if someone hasn't completed their desired childbearing and children for the future, because now that if someone does truly have this, they likely don't have a significant number of viable follicles or eggs left in the ovary to get pregnant with, and the hormones and the regulation around making a normal cycle so someone ovulates is significantly inhibited. And so if someone gets this diagnosis, you have to, and you want pregnancies in the future, you need a referral to a reproductive endocrinologist, an infertility specialist to get evaluated, and potential, trying for pregnancy with a specialist. I mean, someone still can randomly ovulate with this diagnosis. That's why they don't call it failure. That's why they call it insufficiency. To clarify that point that I made earlier, it's insufficiency because it's significantly inhibited, but it's not like it can still happen. But if someone's desiring pregnancy, it would be really hard to get pregnant with this diagnosis, almost impossible. If you like any of these videos, go ahead, give it a like, subscribe. It really helps me out, motivates me to continue to hopefully make more videos to help bring general, reliable information out to the public. And so thank you again for listening and following along. We'll be out soon with the next episode. If you have any potential suggestions, what you want to know about, leave a comment below. We take that into account quite a bit when we're looking to make our next video. So leave a comment, let us know what you're interested in hearing about, everyone. Okay, have a good rest of your day. Thanks again.